Much like NAD, I think there's some misconceptions about methylene blue. So certain people who are certainly going to benefit more from one-methylnicotinamide, and certain people who are going to benefit more from plasmalogens. Because tendonitis develops because there is something else wrong. Other things that we use, if we're looking at neuroinflammatory things, C-Link nasal spray, you'll lose a lot of bone early in menopause as soon as estrogen starts.
Welcome to our Q&A highlights. Q&A sessions are recorded every month, and our enhanced members get an exclusive opportunity to ask questions from one of cellular medicine's brightest minds, Dr. Elizabeth Yurth. Get a chance to ask your questions by becoming our enhanced member at bli.academy/memberships. You also get access to our content library full of tips, articles, videos, lectures, previous live Q&A sessions, and more.
Why does autoimmunity start? Okay, because I think we don't have a great understanding of that. Because it too is actually a mitochondrial disease. So when mitochondria, and why? Well, when mitochondria are damaged, they release their DNA. Now, their DNA is sort of foreign from us. Remember, your mitochondria were little bacteria that moved into you. So they release this DNA, and honestly, our body, our immune system recognizes this mitochondrial DNA as sort of a foreign threat. So oddly, it's our own mitochondria, but their DNA is not really the same as ours, so it's a foreign threat. And it creates, almost like a bacteria, it creates triggers an inflammatory response. Now remember, immune cells need a lot of energy. So you have all these immune cells trying to react to all of these things going on, right? And so they're taking a lot of energy away. And these pro-inflammatory cells rely on glucose metabolism. The anti-inflammatory cells rely on mitochondrial function, oxidative phosphorylation. So now our dysfunction shifts to this glucose metabolism, this pro-inflammatory state, because our mitochondria can't work very well anymore. They've been damaged, and they can't keep up with the energy that the immune system needs. So everything shifts to a pro-inflammatory state. And now the mitochondria are spitting out all these oxidative free radicals, causing further damage, and quality control gets completely messed up. And now we go into this autoimmune state. You'll lose a lot of bone early in menopause as soon as estrogen starts dropping. So a lot of women are waiting too long to start estrogen, and they've already lost some bone. So bioidentical hormone replacement is at the root. Estrogen is absolutely critical, but so is progesterone, so is testosterone. Don't neglect those. Hey, I'm going to throw it in here again. Guess what? GLP-1 receptor agonists like semaglutide, tirzepatide, retatrutide actually show some real promise for bone health as well. Why? Because they actually promote osteoblasts. They promote bone building cells. And then they blunt osteoclasts. Those are the breakdown cells. And they improve the microarchitecture of the bone. Plasmalogens versus 1-MNA. So both critical, great players, Tony. These guys are both, you're right. They're both such good players. It's pretty hard to choose, because there's certain people who are certainly going to benefit more from one-methylnicotinamide, and certain people who are going to benefit more from plasmalogens. And partly that's, looking at the patient, looking at their lab work. Not everybody needs plasmalogens. Most people do, but not everybody. Not everybody needs one-methylnicotinamide. Most people do, but not everybody. So that's where the art comes in, right? If you look at what plasmalogens are doing, they're essential to every single cell, particularly the brain, the heart, the immune cells. They provide structural integrity to the cell membranes, especially in the brain, where they make up 20% of all the phospholipids in the brain. They're really protective against oxidative damage. So they are a pool when we have oxidative stress. They're the first line of defense to us. They support proper neurologic function. They're important for all cell signaling and inflammation. Pretty hard to beat that, right? So they're going to be a key player in Alzheimer's disease, cardiovascular disease, metabolic disorders. But then I've got one-methylnicotinamide. What is it doing? Well, it's improving NAD. NAD is critical to life. Drops as we age, or if we're sick, or if we're injured. So it's absolutely essential to have good high NAD levels. So if I were forced to choose one over the other and I knew nothing about the person I was treating with, I'd probably say plasmalogens. But that's, again, it's going to depend on what I'm treating and what I'm doing and what I'm trying to help that patient with. And in a perfect world, you're going to use both. And maybe if that's expensive, you you cycle back and forth, right? But you're going to use both to restore if you really want to keep your cells at that sort of healthy level, because we need NAD and we need phospholipid structure to our cell membranes. Plasmalogens probably the most important because they are the basic building block. So nothing else is going to work if I don't have plasmalogen supply. The GLP-1s are great, and we know that they have huge benefits to the mitochondria, so that's one of the reasons they help with brain function. We know they have a huge effect to the immune system, so that's one of the ways they help in brain function. I do love tadalafil too. Tadalafil has some very promising neuroprotective effects, unless you're taking a lot of methylene blue, and then it's probably not going to do anything. And then telmisartan you asked about. Telmisartan's interesting. It actually crosses, it's one of the few blood pressure medicines that does cross the blood-brain barrier, and it activates what's called PPAR gamma, and that is going to reduce chronic neuroinflammation, have a lot of neuroprotective effects. I love cerebral lysin, but not orally. There's very little evidence to support that oral cerebral lysin has good bioavailability. So I think you really need injectable cerebral lysin, ideally at higher doses, IV, done with a physician who's ordered it from the right place. And then the MAOB inhibitors, I think they've shown some modest cognitive enhancement in some populations, but that would fall low on my list of things I would do. Other things that we use, if we're looking at neuroinflammatory things, C-Lank nasal spray, oxytocin nasal spray, insulin nasal sprays, all can have some benefits there too. Anything you can do as a nasal spray can get right to the brain, which is really nice. So we do like those types of things as well. So I'm going to get on my high horse about methylene blue, because much like NAD, I think there's some misconceptions about methylene blue. So first of all, I think methylene blue can be a wonderful thing. It really acts at the mitochondrial level to support the electron transport chain. Just like NAD, you look at NAD and you go, wow, this is great. We need more NAD in the cells. I'll put NAD into the system. Let's look downstream, because let's look what else methylene blue does. One of the main concerns is that methylene blue is a significant inhibitor of nitric oxide. It's really multiple mechanisms, but it directly inhibits all forms of nitric oxide synthase, all forms. It also blocks something called soluble guanylate cyclase, which prevents signaling of nitric oxide. And then it oxidizes nitric oxide to reduce its bioavailability. Now, remember what nitric oxide's for, right? We all want a lot of nitric oxide, because what does that do? It makes us have healthy blood vessels. It increases circulation to our brain, to our extremities, to our internal organs. So all these people are out there popping methylene blue like it's nothing and not looking at the downstream effects. So what happens if I inhibit nitric oxide? I get vasoconstriction. That's going to cause increased blood pressure. Potentially, it's going to affect platelet aggregation. Neurologically, when you inhibit nitric oxide, you actually will alter neurotransmission and serotonin. You also get erectile dysfunction, right? You need a lot of nitric oxide for vasodilatation of the penis, so you'll start to get erectile dysfunction if you're using this a lot. So how about we just throw in organic nitrates into the mix? So if I'm taking my methylene blue, let me do a lot of beets or Neo 40 lozenges, or beet juice, or drink beet juice, right? Those are organic nitrates, which is what you would need is to really pump up the organic nitrates. But that will help. But if I keep doing this, you will never be able to fully restore the nitric oxide pathway. And you may get a rebound effect that after those go away, you get a vasoconstrictive rebound. So you can never completely compensate for what methylene's blue is doing to the nitric oxide pathway. So my preference is to use nitric oxide judiciously, never continuously. Maybe you could do it for a week with a lot of nitric oxide support and then stop it, because you've got to get this nitric oxide production going again. Those of you guys who don't know, calcific tendonitis is where calcium deposits form inside a tendon. So it usually starts with a tendon injury. Most commonly, not always, but way more commonly, it's the rotator cuff tendons in the shoulder. And these calcium deposits, this is like, when you get these, like surgically, they squeeze out like toothpaste. It's crazy. So it's this calcium that's deposited into the tendon. It's kind of this soft calcium. And it causes a lot of pain and inflammation and reduced range of motion. So it's usually this calcium hydroxyapatite crystals that deposit. It's most often the supraspinatus tendon in the shoulders. Who does it occur mostly in? Much more common in women than men. So that's a key, right? When something's more common in women and men, what might be affecting, right? Think about hormonal differences there. It's much more common in people 30 to 60 years old, less common in people as they get older, and less common in younger people. It's much more common in people who have endocrine disorders. So anybody who's not metabolically sound, and I'm talking about to a perfect level, metabolically sound, okay? So, or thyroid dysfunction. So the first thing I always think of when I see somebody come in with calcific tendonitis is, this is a person I need to optimize, because they should not have developed calcific tendonitis. Calcific tendonitis develops because there is something else wrong.